Hello, my name is Wilson Miskelly, and this is going to be my head-to-toe assessment for the University of Memphis for fall 2025. Today's date is October 25th, 2025. This is our patient Asia, and we're going to start with a scan of the room. Surfaces, my supplies, a scan of the ceiling, and of the floor. Okay. We will begin with an assessment of the skin of the face, head, and neck. Prior to beginning the video, we did an assessment of the posterior and anterior chest, as well as the abdomen for patient privacy. Overall, we see that the skin color is normal for ethnicity. It is warm, dry, smooth, and the turgor is intact. We see no edema, bruising, scarring, lesions, or nevi present. Moving on to an assessment of the overall head, we see that it is normal cephalic, symmetric, and aligned along the midline. Palpating the scalp, we see that the hair is evenly distributed. The hair is a coarse texture and a natural round color. We see no depressions, no masses, no lesions, no infestations, and no tenderness present. We will palpate the temporal arteries here. We see that they are 2+ and equal bilaterally, and they are non-tender. We will palpate the lymph nodes, starting with the preauricular, the postauricular, the occipital, the submandibular, submental, anterior cervical, posterior cervical, and supraclavicular, all of which are non-palpable and no nodules present. We will move on to an assessment of the cranial nerve number 5, the trigeminal nerve. To do that, we will palpate the masseter muscle. Go ahead and clench your jaw for me, okay, and open your jaw. Motor function is intact. We will move on to sensory function. If you can close your eyes for me and tell me where I'm touching.
Forehead, right cheek, left cheek, nose, chin.
Okay, sensory function is intact. Trigeminal nerve number 5 is intact. We will assess for TMJ. Go ahead and open and close your mouth for me. Okay, no sign of crepitus, subluxation, or tenderness with that assessment. We will assess cranial nerve number 7, the facial nerve. To do that, I'll have you raise both your eyebrows, close your eyes tight, smile, frown, puff out your cheeks, look at your lips. Facial nerve, cranial nerve number 7 is intact. We will move on to an assessment of the ears. We see that the ears are equal and symmetrical bilaterally. We will palpate the tragus and the pinna, and we see no masses or tenderness noted with that assessment. We will move on to an assessment of the auditory canal. Auditory canal is clear, and the tympanic membrane is a pearly gray color. We will move on to an assessment of cranial nerve number 8, the vestibulocochlear. To do that, we will do a couple hearing tests. I'm going to start with the whisper test, which I'm going to whisper 2 words in your ear and you repeat them back to me.
Dog, cat.
Orange, apple.
Orange, apple.
Okay. Whisper test shows no hearing loss noted. We'll move on to the Weber test. To do that, I'm going to place this tuning fork in the middle of your forehead, and you tell me if it's louder on one side or the other.
No.
Okay. Weber test is normal with no lateralization. We will use this tuning fork again for the René's test. To do that, I'm going to place this tuning fork on the mastoid bone as well as in front of your ear, and you tell me if sound number 1 or sound number 2 is louder. 1, 2.
2.
Okay. 1, 2.
2.
Okay. Cranial nerve number 8, vestibulocochlear, is intact. René's test was normal with air conduction greater than bone conduction. We will move on to an assessment of the eyes next. We are looking at the eyebrows, eyelashes, and the palpebral fissures. We see that the hair is evenly distributed. The facial features are symmetrical. And we will now look at the conjunctiva and the sclera. Sclera is white, conjunctiva are pink with no redness, no lesions, and no discharge noted. We will move on to an assessment of optic nerve number 2, which cranial nerve number 2, the optic nerve. For that, I will have you cover your left eye and read off the smallest line for me.
LTFPH.
Okay, now cover your other eye.
LTFPH.
Okay, vision is 20/20 bilaterally. We will move on to test peripheral vision. So stare straight ahead for me. Cover your left eye. Can you tell me what number I'm holding up?
4, 3, 2, 1.
Okay, now your other eye.
4, 3, 2, 1.
Okay, peripheral vision is intact. Cranial nerve number 2, optic nerve is intact. We will move on to assess cranial nerve number 3, the oculomotor. To do that, we will use our pen light. Stare straight ahead for me. Pupils are equal, round, and reactive to light bilaterally, and they are about 3 millimeters in size. We will next test for accommodation and convergence. Follow my pen light with your eyes only. Accommodation and convergence is normal. Cranial nerve number 3, oculomotor, is intact. Next, we will move on to a test of cranial nerves 3, 4, and 6, oculomotor, trochlear, and abducens. To do that, we are going to test the 6 cardinal areas of gaze. Follow my finger with your eyes only. Okay. Extraocular movements are coordinated and symmetrical bilaterally. Next, we will take a look at the internal eye structures. We are looking for red light reflex and at the other structures. Okay, look straight ahead for me. Red light reflex is intact, and the retinal arteries and veins show no narrowing. They're normal in size with no enlargement, no hemorrhages, no lesions, no discharge. Noted in the optic nerve has sharp disc margins. Moving on to an assessment of the nose. The nose is straight and midline. We will test for the olfactory nerve, cranial nerve number 1. Go ahead and close your eyes. I'm going to occlude one nostril, and you tell me what you smell.
Alcohol. Alcohol.
Okay. Cranial nerve number 1. Olfactory is intact. We will now palpate the frontal and maxillary sinuses. The frontal and maxillary sinuses, both of which are non-tender to palpation. We'll move on to an assessment of the mouth and throat. To do that, we will look at the lips, the tongue, the teeth, the gums, the buccal mucosa, the salivary ducts, the posterior pharynx, the tonsils, the roof of the mouth, the palate, and underneath the tongue. If you can go ahead and open your mouth for me. Okay, and stick out your tongue. Tongue to the left and to the right. Good. All structures are normal. Tonsils are grade 1 with no swelling, no redness, and no gum disease noted. We will move on to an assessment of cranial nerves number 9 and 10, the glossopharyngeal and the vagus nerve. To do that, I will have you open your mouth and stick out your tongue and say ah.
Ah.
Okay. The soft palate and the uvula both rose with phonation, which is normal. Those cranial nerves 9 and 10 are intact. We will do a test of cranial nerve number 12, the hypoglossal. We will test our tongue movement, so stick out your tongue. Tongue to the left, to the right, up, and down. All movements are symmetrical with no vesiculation, so cranial nerve number 12 is intact. We'll move on to an assessment of the throat, to the neck. We see that the neck is supple and straight. The trachea is midline and straight. We will palpate the thyroid gland. To do that, we will move the trachea to one side and have our patient swallow. Good, swallow. And swallow. Good. The thyroid gland is non-palpable and there are no nodules noted. We will palpate the carotid pulses, both of which are 2+ and equal bilaterally. We will auscultate with the bell. Take a deep breath and hold it. Good. No bruit noted. You can breathe. We will move on to an assessment of the posterior chest. First of all, we see overall the chest is symmetrical with no obvious deformities. We see no signs and symptoms of respiratory distress, which are nasal flaring, retractions, use of accessory muscles, tripoding, tachypnea, or cyanosis. We will begin by palpating for the chest rising. Take a deep breath for me. Okay, chest rose symmetrically. We will now palpate for tactile premises, say 99 with each touch.
99, 99, 99, 99.
Okay, equal vibrations throughout. We will listen to some lung sounds. Just take a breath in with each touch. Good. Lung sounds clear and equal bilaterally. We will now listen for whisper pectoriliquy. To do that, we will have you whisper 99 with each touch. Okay, whisper pectoriliquy. Now we will do bronchophony. Do that, say 99 with each touch.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay, now we'll do egophony. Say E with each touch.
E, 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 E.
Okay, and now we will percuss the lungs and the intercostal spaces. Okay, resonance heard throughout. We will move on to an assessment of the anterior chest. Again, we see the chest is symmetrical with no obvious deformities. We will palpate for tactile fremitus. Go ahead and say 99 with each touch.
99, 99, 99, 99.
Okay, equal vibrations heard throughout. We will go ahead and listen to some lung sounds. Again, just a breath in with each touch. Lung sounds clear and equal bilaterally. We'll move on to listen for some heart sounds. To do that, we will start with the aortic valve on the right sternal border at the second intercostal space, the pulmonic, which is at the left sternal border at the second intercostal space, Erb's point, which is at the third intercostal space at the left sternal border, tricuspid valve, which is at the left sternal border at the fourth intercostal space, and the mitral valve, which is at the left midclavicular line at the fifth intercostal space. This is also the point of maximal intensity, and I feel no abnormal pulsations. I will listen for the apical pulse for 60 seconds normally. Apical pulse is 83 for our purposes and with a normal sinus rhythm. We will again listen with the bell of the stethoscope to the aortic at the right sternal border, second intercostal, pulmonic at the left sternal border at the second intercostal, at Erb's point, left sternal border, second intercostal, tricuspid, third intercostal space at the left sternal border, and the mitral at the fifth intercostal space at the left midclavicular line. Both of those auscultations with the diaphragm and the bell show S1, S2 noted with no murmurs, no gallops, and no extra heart sounds noted. We'll go ahead and have our patient lay down, and we will be assessing for JVD. We'll have her lay at a 30-degree angle. Okay, with her head turned to the left. We are looking at the sternocleidomastoid. We feel and see no obvious pulsations. We'll have her go ahead and lay flat. Quick scoot down for me just a little bit. Okay. We see and feel no heaves or lifts. We will palpate those heart areas for thrills, starting with the aortic, pulmonic, Erb's point, tricuspid, and mitral. No thrills noted. We will listen to those heart areas again with both the diaphragm and the bell, starting with the aortic, pulmonic, Erb's point, tricuspid, and mitral. With the bell, aortic, pulmonic, Erb's point, tricuspid, and mitral. S1, S2 heard with no murmurs, no gallops, no extra heart sounds, no bruits. Let's see. We'll move on to an assessment of the abdomen. Overall, we see that the abdominal contour is flat and symmetric with no obvious masses. We will go ahead and palpate in all four quadrants, as well as palpate the liver and the spleen. Liver and spleen are both non-palpable. There is no palpable masses or tenderness noted in the abdomen. We will go ahead and listen, auscultate with the diaphragm. We're going to start by listening to the arteries of the abdomen with the bell. We'll listen to the aorta, no bruit renal arteries, no bruit iliac arteries, no bruit femoral arteries, no bruit. We will listen to bowel sounds in all 4 quadrants of the diaphragm. Bowel sounds are normal active. We will percuss all 4 quadrants, as well as over the liver. And take a deep breath in. Okay, you really breathe out. We see tympany, or we hear tympany throughout, with dullness over the liver and tympany over the spleen. I will have our patient go ahead and sit back up. Have her sit with her back facing the camera. We're going to percuss for CVA tenderness on the left side and the right side. CVA tenderness is negative. Have you turn around here. All right, we're going to move on to an assessment of the musculoskeletal system. To do that, we are going to start with an assessment of the upper extremities, which is going to be the fingers, the wrists, the elbows, and the shoulders. Our inspection shows no redness, no swelling, no deformities. Palpation shows no crepitus, no tenderness, and no nodules present. We will palpate for capillary refill. Capillary refill is less than 3 seconds bilaterally. We will palpate radial pulses, both of which are 2+ and equal bilaterally. We will move on to do range of motion, starting in the fingers. If you can, just mimic these motions with me. Do flexion, extension, abduction, adduction, thumb opposition. Good. Full range of motion in the wrists. In the fingers. We will move on to the wrists. Flexion, extension. Flexion, extension, hyperextension, ulnar deviation, radial deviation, and rotation. Good. Full range of motion noted there. We will move on to the elbows. We will do flexion, extension, and hyperextension. Good. Full range of motion in the elbows. Now the shoulders. We will do flexion, extension, hyperextension, internal rotation, external rotation, abduction, and adduction, both across, and then circumduction. Good. Full range of motion noted in the shoulders. We'll move on to strengths. We will do grip strength first. Squeeze my fingers. 5 out of 5 strength there. Bend up your arms. Push me out. Pull me in. 5 out of 5 strength there. Now the shoulders. Arms out to the side. Push me up. Pull me down. 5 out of 5 strength there. We will move on to an assessment of the accessory nerve, the cranial nerve number 11. Shrug your shoulders. Cranial nerve number 11 is intact. We will do cerebellar coordination. To start, we will do finger opposition, so mimic my motions again. Good. We will do hand flip-flops, so we will do supination and pronation of the hands. Good. We will move on to the finger-to-finger test. I need you to touch your nose and my finger. Nose, finger, nose, finger, nose, finger. Good. The other hand. Nose, finger, nose, finger, nose, finger, nose, finger. Good. It's all normal. We'll move on to stereognosis. To that, go ahead and close your eyes and identify this object for me.
Key.
Okay. And this object?
Pin.
Okay. We will move on to graphesthesia. Go ahead and keep your eyes closed. I will draw something in your hands, and you tell me what they are.
T. S.
Good. Now your other hand.
T. S.
Good. Graphesthesia is normal. We will move on to an assessment of light sensation in the upper and lower extremities. To do that, I'll have you close your eyes and you tell me where I'm touching.
Right arm, left leg, right leg.
Okay, good. Light sensation is intact. Our overall examination of the extremities show that the color is normal for ethnicity. There is no edema. The turgor is intact. It is smooth, dry, and warm. We will measure vibratory sensation now. To do that, I'm going to place this tuning fork on your wrist and your proximal ulnar prominence. Can you feel both of those?
Yes.
Okay. Now tell me if you can feel this on your wrist.
Yes.
Okay. Proximal ulnar prominence.
Yes.
Good. Now we will do the medial malleolus. Tell me if you can feel this.
Yes.
Okay. And this.
Yes.
Good. Vibratory sensation is intact. We'll move on to deep tendon reflexes, starting with the brachioradialis. Relax your arm for me. Okay. Next, we'll move on to the bicep tendon here. Just relax for me. And relax. Good. Now triceps. Okay. Good. Now we'll move on to the patellar tendon. Good. And the Achilles tendon. And then the Miskelly reflex. Can you see all the way down here? I don't think. Let's see, that's the Achilles and the Babinski. Good, all that is good. I'm gonna have you stand up and scoot back just a little bit. Go ahead and sit back down. We're gonna move on to an assessment of the lower extremities and the joints that are in. We will start with just an overall inspection. We see that the joints of the toes, the ankles, and the knees have no swelling, no deformities, and no redness. We feel no crepitus, no nodules, and no tenderness. We will assess for capillary refill. Less than 3 seconds bilaterally. We will check the dorsalis pedal pulses, which are 2+ and equal, and the posterior tibialis pulses, which are 2+ and equal bilaterally. We will then go ahead and do range of motion in the feet, in the toes. So mimic these motions with your toes for me. We will do flexion, extension, abduction, and adduction. Good. We will do range of motion in the ankles. We will do plantar flexion, dorsiflexion, eversion, inversion, and rotation. Good. Full range of motion noted in the ankles. We'll now do strengths of the ankles. We push up on me and push down, push up and push down. That's 5 out of 5 strength there. Push out, pull in, push out, pull in. 5 out of 5 strength there as well. Now we will move on to an assessment of range of motion in the knees. To do that, we will start with the right leg. We will do flexion, extension, hyperextension. Good. Now this knee, flexion, extension, hyperextension. Good. Full range of motion noted in the knees. We will do range of motion in the hips now. Starting with the right, we will do flexion, extension, hyperextension. We will do abduction and adduction, internal rotation, external rotation, and circumduction. Good. We will now do the left. We will do flexion, extension, hyperextension, internal rotation, external rotation, abduction, adduction, and circumduction. Okay, now I need you to push out on my hand with your leg. You lift up the whole thing. Just out like that.
Oh.
There you go. And in. Okay. Out. And in. Good. 5 out of 5 strength there. We will move on to an assessment of the spine. See that the spine is symmetric with no deformities or tenderness. Go ahead and flex forward just a little bit for me. We see that there is no scoliosis or kyphosis noted. Shoulder blades are symmetrical. We will move forward, which is flexion, straight up, extension, hyperextension, do lateral rotation, and then rotation. This is lateral flexion, and then the rotation at the end. Good. Now we will move on to the cervical spine. To do that, we will have our patient chin to chest, which is flexion. Straight up is extension, back is hyperextension. We will do a lateral flexion, and rotation. Okay, I'll go ahead and have you stand over there and walk towards me. Okay, turn around and walk back heel to toe. Good, and come stand next to me. We'll do Romberg side next. So both palms up, hands up high, and no swaying noted. We will have you hop on one foot and hop on the other foot. Good, this completes my head to toe.